The chest X-ray is the most commonly used diagnostic imaging tool in clinical medicine. As a medical student, resident, and practicing physician, it's important that you understand the basics of approaching the chest X-ray. In this tutorial, I will explain how an image is obtained and give you an understanding of what you should look out for when you're first approaching a chest radiograph. X-rays are a form of high-energy radiation produced somewhat analogous to the beam radiating from this flashlight. The object sitting between the source and the image receptor casts a shadow, which is then recorded by the image receptor represented by the white wall. This is what produces the image that is viewed as a radiograph. When thinking about radiographs, it's helpful to imagine that the receptor starts out all white, but when struck with an X-ray, turns black. If a dense object like this metal ball blocks the X-ray, it leaves a white impression within its shadow. Let's explain why some parts appear brighter than others. The ability of an X-ray to pass through an object is a function of the density of the object. The more dense an object, the more energy it can absorb. The more energy an object absorbs, the less energy reaches the image receptor, leaving it more white in that area. Notice that the most dense cube leaves the brightest impression on the image receptor. Just as denser objects will produce wider shadows, a thicker object will have a similar effect. Here we have 1 cube, 2 cube, and 3 cube thickness from left to right respectively. Notice how the stack of 3 cubes produces the most white shadow, similar to the most dense cube in the previous demo. Sometimes you'll hear doctors describe chest X-rays as either being an AP or a PA radiograph. So what do these mean? These simply describe the technique that was used to obtain the image. When a patient is unable to get out of bed in the ICU or the ER, for example, an AP radiograph is obtained. The X-ray source is from a portable machine that is placed in front of the patient. An image detector is placed behind the patient. When the chest X-ray is actually taken, the X-ray beams pass from the front to the back or anterior to posterior of the patient. Thus, this would be called an AP radiograph. The PA radiograph is obtained differently from an AP. Like its name implies, the X-ray beam passes posterior to anterior of the patient, but this is not the only difference. PA X-rays are acquired with the patient standing upright, with their hands on their hips and their elbows out to the side. This allows the heart and lungs to be optimally and accurately visualized. The PA film has other technical advantages. Since the X-ray source can be placed much further behind the patient, sharper outlines can be obtained. I will demonstrate this concept. Imagine the X-ray source as being this flashlight on a track. As we move the flashlight closer to the object, let's say it's an organ, notice how its shadow becomes fuzzy, larger, and less distinct. As we pull it back, the shadow reemerges as being distinct, clear, and less magnified. So that's the idea. Rotation. When an X-ray is taken, the patient's coronal axis should be as perpendicular to the X-ray beam as possible. If they're not perpendicular to each other, the patient is said to be rotated, which produces a technically inadequate film. Let's demonstrate the concept of rotation. To help you understand the concept of rotation, take a look at this 3D diagram. The green arrow represents the direction of the X-ray beam as it passes through your tissues and strikes the image detector represented by the white box. The blue rectangular boxes are supposed to represent your clavicles, and the red line of cubes are supposed to represent your vertebral bodies. Now we're going to fly over. This gives us the perspective of looking the patient face to face, the same perspective that you get when viewing a properly displayed radiograph. This means, for example, that the right clavicle here is actually on the left, and the left is actually on the right. This is a standard view. Now take a second to orient yourself to the three views that we've provided. The first view, leftmost here, is actually a view from the top. You're looking down at the patient's head. The top of this box here represents anterior and the back is posterior. Now, the middle view gives us a more three-dimensional looking view that is from the patient's left shoulder. You're looking over it. The last view here on the right gives us the perspective that we just ended up seeing, meaning you're looking at the patient face to face. That means the right clavicle is actually on the left side and the left clavicle is actually on the right side. Now notice what happens when we rotate the patient a little bit. So if we rotate to the left, meaning that the patient's left shoulder, for example, is a little closer to the image plate than the right. If you notice here on this radiograph perspective view that the medial head of the clavicle appears to be closer to the vertebral body than the right side. So this is how you can actually tell if the patient is rotated on a chest radiograph. If you notice that the vertebral bodies or the line of spinous processes are actually closer to one medial head of a clavicle than the other, then you can tell which way the patient is rotated. For example, now that the patient is rotated a little to the left anteriorly, this is called a left anterior oblique rotation. So let's talk about why this is important to know. Take a look at why rotation matters. When the patient is rotated so that the right shoulder is angled towards the image plate, this is a right anterior oblique view. The heart tends to appear larger and more elongated. When the patient is rotated just the opposite way, this is a left anterior oblique view. The heart appears less elongated and more globular. Here are both views, side by side, for your comparison. Let's run through reading a normal chest x-ray. First thing, ensure that you have the correct patient film. Make sure that the patient's name, date and time the film was taken, and film ID number match what you're looking for. Do a quick survey for technical quality. Look for proper inhalation, signs of rotation, and correct penetration. Begin assessing the structures. You must be systematic. In other words, you should have a sequence that you run through each and every time for each and every film. Make sure the sequence covers all structures. You want to be thorough and complete. Let's run through a sample sequence. Start up top. Examine the soft tissues of the neck, shoulders, and axilla. Sweep down the center, looking for fractures of the sternum. Examine the upper abdomen, which is directly underneath the diaphragm. The right hemidiaphragm should be higher than the left due to the presence of the liver. It should be about 1.5 to 2 centimeters higher. A gastric air bubble is normally visible under the left hemidiaphragm. Look for signs of free air directly beneath the diaphragm. Examine the bony structures. Look out for fractures, lesions, and joint disease. Start at the top cervical spine and move down the vertebral column. Examine each vertebra and each disc space, pedicles if they're visible, and spinous processes. Examine each clavicle, AC joint, coronoid process, glenoid fossa, and humerus. Look at each and every rib. Once these structures have been examined, proceed to the lungs and the mediastinum. Break down the lungs into horizontal thirds so that it's easier for your eyes to focus on individual sections. Examine each third for abnormalities. Examine the hilar structures and pulmonary vasculature. Do the pulmonary arteries look normal? Are enlarged lymph nodes visible? Find the tracheal air column and locate the carina, which splits the trachea into the right and left main stem bronchi. Is it centered? Look at each costophrenic sulcus. Are they sharp and distinct? Now examine the size of the heart. Is it enlarged? If so, are technical errors to blame? For example, is this an AP film? The heart to widest horizontal length should not be greater than half the length of the chest. A quick method to do this is to mentally cut out the heart that lies to the right of the midline. Transpose this to the left. If the leftmost border lies within the thoracic cage, it should be okay, but if not, the heart may be enlarged. Now examine the entire border of the mediastinum. Start on the bottom right and move clockwise. The right atrium forms the right heart border, which abuts the middle lobe of the right lung. Just superior is the right pulmonary artery. The superior vena cava joins from above. The arch of the aorta forms the prominent aortic knob. Just below is the main pulmonary artery, with the left pulmonary artery coming out. Inferior to that is the left atrial appendage. And just inferior to that is the left ventricle, which forms the majority of the left heart border. This completes our survey of the structures on a normal chest radiograph. As you become more familiar with what normal looks like, abnormalities will stand out to you. But always remember to be systematic when approaching the chest film. Not doing so may lead to missed findings and misdiagnosis, which may negatively alter the course of patient care. Thank you for watching.